we begin to emerge from the COVID pandemic, I think it's very important that we take time to look at our world from a high point of view and consider where we are now compared to where we used to be, and then discuss where we'd like to go as a society. It's been since 2019 that we were together again, and as we unmask, let's look at where we were in Birmingham as a group. You can see what a close-knit society we are. You can also appreciate that there are several members who are no longer with us, and we mourn them. There are also members who can't be here today because of health and personal issues that prevent long travels. For them, we'll keep them in our prayers and wish them a speedy recovery, hoping to see them again soon. So to recap this year in review, we began to unmask initially with the WFNS meeting in Bogota, which was highly successful. And you can see a number of our ISPN members together at that meeting where we had the opportunity to meet and brainstorm, as well as to renew our acquaintances. That next month brought the Brazilian Congress in João Pessoa, northern coast of Brazil. And this is fascinating because if you look at these pictures, you would almost think that the Brazilian Congress is all female neurosurgeons. And one of my favorite pictures is this picture with Nelsie Zanon and the huge number of medical students and aspiring young pediatric neurosurgeons that she has mentored. Mentorship is a dish best served warm and in person, and you can see the results of an exceptional mentor and those that she has inspired making up the Brazilian Congress here. It was a fantastic meeting. In May, a group of us met in Geneva along with the leadership of the G4 Alliance. And at this meeting, Kemal Gatmi, whom you see here, and others presented a proposal for a resolution calling for mandatory folic acid supplementation universally to reduce the global incidence of spina bifida. And you can see here Key Park and Walt Johnson with Dr. Tedros from Ethiopia, who is the director of the World Health Organization. Moving forward through advocacy, and you can see this dinner here that we held is the first William Hartness Memorial Dinner in one of William's favorite restaurants where he attended with Gail Rousseau in the past. The next month brought the International Meeting of Pediatric Hematology Oncology in Oaxaca, Mexico. 350 hematologists and oncologists from the Caribbean, Central and South America convening to talk about childhood cancer. Oaxaca is interesting in that it's a food city, and one of their favorite foods is insects. And you can see here in the open market dishes full of fried crickets, fried ants, and other insects for sale for dinner. In July, we held our first educational course in Lima, Peru, sponsored locally by Dr. Herman Posada here, a senior pediatric neurosurgeon. And you can see in this picture where we had a celebration of 35 years of pediatric neurosurgery in Lima, Peru, and a number of the attendees from around the world here. It brought forward the importance of in-person meetings and the fellowship that we enjoyed together with our colleagues from Peru. In August, I was fortunate enough to be invited by Dr. Deo Pujari to present the Gindi oration, which is an honorific in Mumbai. And you can see the celebration here and the large number of young pediatric neurosurgeons who are in attendance there. We also had the opportunity to round at Dr. Deo Pujari's Children's Hospital in Mumbai, which is now over 100 years old and a very busy place. While this was going on, just down the street in Kolkata, Nelsie and Jeff Blount held the second educational course in Kolkata with Sandeep Chatterjee, Art de Kunha, and others. They had just come from the Andhra University where they had held a spina bifida symposium, and you can see the audience here with over 1,500 interested people in attendance as Yogi Patisipu lectured to them about the benefits of folic acid supplementation and fortification to prevent spina bifida. And these sacs contain salt fortified with folic acid in a study that they're performing looking at blood levels of folic acid in mothers who take this fortified nutrient. In September, a very successful Australasian Congress held in Jerusalem, put together by Shlomi Constantini, Andrew Kay, and colleagues. And you can see our local president for that meeting was Juan Tussaud, one of the few pediatric neurosurgeons that I know who can preside over 2 world congresses within a 6-month period of time. This was followed immediately by the first International Palestinian Congress of Neurosurgery held in Ramallah. And you can see the group of us here in Ramallah putting on a 2-day symposium. While we were there, a 7-year-old came in with a posterior fossa tumor, and Samer El Baba and Lissa Baird changed their flights to stay and help operate on this child and remove her posterior fossa tumor successfully. In October, a group of us met in Cape Town as an alliance between St. Jude and the Red Cross Children's Hospital there. You can see what a beautiful place Cape Town is, and gracious hosts Tony Fagaji and Graham Fegan. Unfortunately, I developed COVID at that meeting, and my in-hospital attendance was somewhat limited, but we were able to enjoy fellowship in outdoor settings safely. So let me take some time to review our most recent membership surveys. This first is an exit poll of our virtual meeting in 2021. And you can see at that time we had over 1,200 registrants for our annual virtual online meeting, enjoying between 450 and 550 unique logins per day, and between 150 and 200 members attending each of the lecture sessions. What we recognized is that the virtual meeting went well, and that a number of the attendees liked having a virtual as well as an in-person option in the future. The exit polls showed that 95% of the attendees felt that the meeting met their expectations and that the topics were nicely selected. When we look at what the preferences were for the future, a majority said that they would prefer a virtual meeting where they had the option to attend in person or not, but a robust number of members yearned for a return to in-person meetings. By the next year, our 2022 membership survey following that virtual meeting echoed the same sentiments, but more people by that time were interested in returning to an in-person meeting with a virtual option for those who were unable to attend. This exit poll went out a year ago in December, and it was sent to 590 ISPN members with a 50% response rate of 232 responses. And thank you to all of you who took the time to fill out this rather comprehensive survey. I'll share the information with you now. Here are the countries from which the responses came. The top 4 were the United States, Brazil, India, and Japan, but you can see we had representation from around the globe in these survey responses. When we divided them into World Bank income levels, you can see that 50% of the responses came from high-income countries, 30% from upper middle income countries, 20% from lower middle income countries, and a fairly limited response by low-income countries. When we look at our membership, we are now up to 567 members, with a significant proportion of those being women. And when we break it out by decile, it's interesting that in our younger membership, a third of our members are now female, which is exciting to see. We implemented a diversity, equity, and inclusion committee this year, an ad hoc committee, which will help us in the future ensure that we have equal representation from all groups from around the world. Most of our members are active members. We are now down to 7 nursing and allied health members, but Jenny Sackery has done a beautiful job of putting together a hybrid meeting this year and has over 70 nurses from around the world registered to attend her nursing symposium at our meeting in Singapore. In terms of communication preferences, the vast majority of our members would prefer communication by email. Second only to that is WhatsApp, Telegram, and WeChat as a way of communicating with our society members. When we look at what our membership would like, it's important, again, to note that 95% of our membership requests more mentoring. And so whereas we now have a plethora of online educational opportunities that are no cost, it points out the importance of in-person, face-to-face encounters as a means of providing mentorship. And you can see by the responses here to our survey, we're hearing again and again that people want not just educational opportunities, but actual mentorship, networking, and international pediatric knowledge, more usable forums such as WhatsApp and other social media platforms, educational courses, consultant level, continuous professional development programs, ISPN leadership mentoring, platforms through which membership surveys can be disseminated easily, etc. Access to meetings, continual virtual streaming options for meetings, developing consensus statements, etc. When we look at the ISPN activities, the meetings, virtual meetings, had the highest attendance, but we're right there with Clash of the Titans webinars, and then our annual physical meeting just behind that. Again, the future meetings requested were a hybrid option, but the majority of people would like to have an in-person meeting when possible. When we look at what our members are doing, 148 members have said that they would like to be more involved in writing chapters and participating in our second edition of the guide, our long online ebook. 146 responded that they would like to work in collaborative research efforts, and we now have Jonathan Roth's new clinical research committee, which is gathering data from around the globe to report manuscripts on pediatric neurosurgical diseases. We also have 156 members who are interested in being involved in our annual meetings, either by reviewing abstracts, chairing sessions, or being a part of panel discussions. The child's nervous system, 73% of you said that this was your preferred journal for publication. And when we look at our membership, the vast majority are active members. Senior member is anyone beyond training in this question, so we broke it down further. And as you can see, our largest membership category is now those who've been in practice for over a decade, but a large number of younger members as well. When we look at main reasons to join, networking in an international setting, access to internationally recognized experts in pediatric neurosurgery, and joining a group of peers are the main reasons to be a member. When we look at those in practice and their catchment area, we think that typically it takes a population of 1 million people to support one subspecialist in pediatric neurosurgery. And here are your responses, with a catchment area of 1 to 4 million people being most common. Many work in a public hospital, but a number work in private hospitals, and a number also work in both. When we look at whether the hospital is incorporated into a general hospital as a ward or a wing that's pediatric versus freestanding, it's almost an equal mix. The majority take call at least every 4th night, and some take call every night. When we look at dedicated neurosurgical beds, most of us have dedicated neurosurgical beds, and the majority of us work in a neurosurgical training center, an academic center, sometimes with general surgery, but most commonly a neurosurgical training center. We have 40% of the membership who reported that they have a fellowship program as part of their pediatric neurosurgery center, and 15% relayed that they have a duality with another training program or a twinning program with another institution. These may be Duke in the United States, Alderhay in Liverpool, Cairo, Muhammad's institution there, National Children's Medical Center in Russia at the Burdenko, St. Jude Children's Hospital in the United States, collaboration between Italy and Uganda, etc. In terms of capacity, 90% of members reported that they have a pediatric intensive care unit in their hospital in which they can manage their postoperative patients, and 85% reported having a dedicated neonatal intensive care unit. Almost 50% have inpatient rehab. Many have a dedicated neurosurgical ICU just for their neuro patients. In terms of transport capacity, 70% reported having a dedicated pediatric or neonatal ground ambulance. 40% have a helicopter. Almost 55% have subspecialty fellowship trained pediatric emergency room physicians. 75% have dedicated pediatric anesthesiologists, pediatric critical care physicians, and 2/3 have specially trained pediatric neurologists in their training center. In terms of operating room capacity, 80% reported that they have dedicated neurosurgical operating rooms. 90% have neurosurgical endoscopes. Over 90% have neurosurgical microscopes these days. Almost 70% reported having frameless stereotactic image guidance. 75% have intraoperative ultrasound. 15% have intraoperative MRI. And over 80% report having the ability to perform intraoperative neurophysiological monitoring. In terms of most common types of surgeries, no surprise, shunts and spina bifida, hydrocephalus and spina bifida comprise the #1 surgery that pediatric neurosurgeons perform, followed by brain tumors and trauma-related neurosurgical procedures. But surprisingly, almost a quarter of the programs have epilepsy surgeries, craniofacial surgeries, etc. When we look at multidisciplinary specialty clinics, over 70% now have multidisciplinary brain tumor clinics. 60% have multidisciplinary spina bifida clinics. Over 50% have dedicated craniofacial and epilepsy clinics. 70% reported having a formal quality improvement program at their hospital, and 35% have a dedicated research nurse to help them with data collection. When we break all of these out by income countries, the only thing that was statistically significant was that in lower income countries, they had fewer dedicated neurosurgical beds. Otherwise, there were no significant differences across the spectrum. And you can see this here again, showing no significant difference between the low and middle income countries, upper middle income, and high income countries, except that the lower income countries were more likely to have fewer dedicated neurosurgical beds. In terms of brain tumor volume and numbers of tumor resections, there is no statistically significant difference between groups. And you can see this outlier is Muhammad's brain tumor program in Cairo, which is now the largest in the world. So in terms of the future, let me put things in to my perspective for you. This is our world. In the Northern Hemisphere, population growth is relatively stable. In the Southern Hemispheres, population growth is logarithmic. And remember that in many of these developing countries, 45% to 50% of their population is aged 18 and under. So 2 weeks ago, our world enjoyed the 8 billionth child born, and we currently have 4 births per second compared to 2 deaths per second. So we're in an accelerating pace in terms of population growth. We have 140 million live births per year. And when we look over the past 2 decades at childhood mortality, that is the mortality in ages 5 and under, we've gone from 12.6 million deaths to 5 million deaths in our world, or a 60% decline in childhood mortality in the past 2 decades. So with 140 million births per year and relatively fewer infant deaths, for the 3,000 pediatric neurosurgeons in our world, we now see 46,000 new children for us to care for each year. And when we stop to consider that it takes almost a decade to train one pediatric neurosurgeon, the average pediatric neurosurgeon by surveys performs about 225 cases per year. The question comes, how are we going to take care of all of these children in our world? So when we look at causes of death in our world, the number one cause worldwide is accidents and injuries. And if we look at this, the World Health Organization Sustainable Development Goal 3.6, it calls for a 50% reduction in death from road traffic accidents by the year 2030. Well, the 69 million cases of traumatic brain injury in the world per year, we recognize that 80% of those patients will recover with supportive care and may not need surgical intervention. But we have over 5 million who die from traumatic brain injuries per year, 14,000 people per day, which accounts for 9% of the world's deaths in any given year. 90% of these occur in low and middle income countries, and the global unmet need for neurosurgery related to traumatic brain injury exceeds 2 million cases per year, a tremendous time-consuming business for pediatric neurosurgeons worldwide. When we call for a reduction in traumatic deaths by 50% by 2030, we wonder whether that's possible. But when we looked in the United States, we've been able to demonstrate over a 50% reduction in motor vehicle-related deaths in the last 2 decades. Safer cars, passive restraint systems, better roads. Unfortunately, in our country, another sickness has come to light, and in the United States, the number one cause of childhood death nowadays is related to a gunshot wound. The horrible statistic is a significant increase in the COVID era in the number of children dying from gunshot wounds in the United States. And again, this is something that we'll have to confront through advocacy and governmental reform. In terms of the world, you can see in developing countries unsafe cars, unsafe drivers, poor quality roads, and all of this will come together to present a challenge. But we have multiple groups meeting globally to study the situation, and hopefully in the next couple of decades, we can come up with a reduction globally in road traffic accident related deaths. The number 2 cause of death in children is cancer. And historically, the number 1 cancer-related mortality has been acute leukemia. But in recent years, 85 to 90% of these children can now be cured. So in the current era, a brain tumor has become the number 1 cause of cancer-related mortality in childhood. Related to this, the World Health Assembly passed a resolution in 2018 held out as the GICC, or Global Initiative for Childhood Cancer, recognizing that currently 400,000 children in our world, or just over 1,000 children per day, are diagnosed with cancer. And the target is to reduce the childhood cancer-related mortality by 50% by the year 2030. The World Health Organization has recognized 6 index cancers that are prevalent in all countries, highly curable with proven therapies, and represent a majority of cancers. And for neurosurgeons, low-grade glioma is the number 1 type of brain tumor in childhood. And what we recognize is that 80% of children with cancer in high-income countries will survive, whereas 20% or fewer will survive in low and middle income countries. But 80% of childhood cancers occur in LMICs, and 90% of childhood cancer-related deaths occur in these countries. So when we look at the distribution of diagnoses, recognizing that in developing countries, less than half of children with cancer will establish a diagnosis, we can anticipate that in future, as we have more cancer registries in developing countries, that those numbers may actually double over the next couple of decades. And the frightening statistic is a 10-fold difference in survival in childhood cancer in developing countries versus LMICs, with the notable statement that the 5-year survival of a child with a brain tumor is not determined by the histology of their tumor, but rather by where they receive their care. When we think about spina bifida and hydrocephalus, again, the number 1 operation that neurosurgeons spend time doing, we must recognize that it has now been 30 years since we have had class 1 evidence from the Medical Research Council in the UK demonstrating that 72% of children with spina bifida and anencephaly could be born as normal children if their mothers had access to periconceptual folic acid. And yet, worldwide, it's still a minority of countries that fortify. And it was only this last year that the UK introduced global fortification in their country to reduce the incidence of spina bifida. We currently have around 250,000 spina bifida babies born per year, and that could be significantly reduced with the global access to periconceptual folic acid. This is a nice study in Ethiopia demonstrating that over 10,000 babies born with spina bifida annually. And you can see the timeline here as these increase and what the impact of spina bifida, of periconceptual folic acid would have in this country, where they have 100 neurosurgeons trying to take care of over 10,000 babies born with spina bifida per year. But with global fortification in their country, that would drop to about 1,500 babies per year, and an estimated 37,800 surgical hours diverted that could be used for other needs. So our ISPN developed a position statement on folic acid supplementation in 2021. This was published, and here you see GAPS-BIF, which is the Global Alliance for the Prevention of Spina Bifida sensitive to folic acid. This consortium was put together by Jeff Blount and Gail Rousseau. And again, you can see Kemal Ghatmi and members who working through the G4 Alliance met in Geneva to introduce a resolution calling for universal folic acid supplementation as a means of preventing spina bifida worldwide. And that will be deliberated in this next year, and hopefully we can move it forward. But the G4 Alliance now has over 70 member organizations, and I would strongly suggest that the ISPN become one of these supportive member states. Likewise, Intersurgeon, begun by William Harkness and Jim Johnston, is a means of setting up communicative relationships by high-income countries and developing countries, and the ISPN owes it to our membership to continue to support Intersurgeon as well. So in 2023, I would suggest the following. Number one, our membership wants mentorship. We need to develop mentorship programs that can bring along our junior members, can lead to better communication between our members in person rather than just virtually. Number two, we need to increase our neurosurgical capacity by working with surgical alliances such as Intersurgeon and G4. And I would charge our ISPN liaison committee that becoming a member of the G4 Alliance will be an investment in our future. Remember that our communications committee communicates with our membership, but our liaison committee communicates with other professional organizations. We need to advocate for safer roads, safer cars, safer transportation, and support the WHO initiative to reduce road traffic deaths by 50% or greater in the next couple of decades. We need to advocate for multidisciplinary centers of excellence in pediatric neuro-oncology to reduce childhood cancer-related deaths. And finally, advocacy for universal fortification of diets with folic acid to prevent spina bifida. So please, if you're interested, join our new ISPN advocacy committee and come to Geneva this spring to join us in putting forward our resolution. So I'd like to thank you again for the opportunity to be your present this year. It's been a fast-paced year, but I feel as though we've accomplished many things. And I would leave you with this quote from one of my favorite American presidents: "Ask not what the ISPN can do for you, but what you can do for the ISPN." Thank you very much.